Good afternoon, everyone. We're going to get started in just a minute. We have some attendees entering the webinar, so we'll get started in just a moment. All right, we'll go ahead and get started. Hello, and thank you for joining us today. My name is Ruthie Marker. I'm the Education Program Manager at the Allergy and Asthma Network. I'm excited to welcome you to this afternoon's webinar. We have a great session planned, and I'm pleased to introduce today's presenter, Dr. Karla Adams. With her extensive knowledge of allergy and immunology, we can look forward to an enlightening session. Before we start today's program, I'd like to cover a couple housekeeping details. First, all attendees will remain muted during the webinar to minimize any distractions. We will record the presentation today and upload it to our website in a matter of days. You can access all of our recorded webinars at allergyasthmanetwork.org. Scroll to the bottom of the page to access past webinars and future events. Our webinar is scheduled to last 1 hour, and this will include a dedicated question and answer segment. Although we will answer as many questions as we can at the end, please feel free to submit them at any time using the Q&A box located at the bottom of your screen. One of our team members will be monitoring the chat for any questions you may have or assistance you may need throughout the webinar. We will do our best to address as many of your questions as possible before we conclude today. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. ACAAI offers continuing education credits for physicians and attendance credits for others. You can create a free ACAAI account to earn CMEs or attendance credits for any Advances webinars via their member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after today's webinar, you will receive an email containing supplemental information with a link to download your certificate. We will also share the link to the certificate in the chat. So with that, let's get started. Today's presentation is titled Asthma and Pregnancy Special Consideration for Expectant Mothers. Asthma is one of the most chronic conditions affecting pregnancy, and its management requires careful balance to ensure maternal and fetal well-being. This webinar will provide healthcare professionals with critical insight into the psychological changes of pregnancy that impact asthma control, evidence-based treatment strategies, and practical approaches for educating and supporting expectant mothers. Attendees will leave with a deeper understanding of how to optimize asthma care during pregnancy and improve outcomes for both mother and baby. It is my pleasure to introduce today's presenter. Dr. Karla Adams is Associate Professor of Pediatrics and a practicing allergist in San Antonio, Texas. She obtained her medical degree from the Uniformed Service University and then completed a pediatric residency and Allergy and Immunology Fellowship at San Antonio Uniformed Services Health Education Consortium in San Antonio, Texas. She is currently the program director for the Allergy and Immunology Fellowship at Wilford Hall Ambulatory Surgical Center in San Antonio, Texas. Thank you again for being here, Dr. Adams. I will turn it over to you.
Sorry, there's my volume. Thank you so much for that kind introduction. I'm excited to be here to speak to you today. For disclosures, I don't have any disclosures at this time. So these are our learning objectives. So we are going to talk about we're going to try and work through the impact of asthma on both maternal and fetal health with an emphasis on exacerbation risk as well as pregnancy-related complications. We're going to talk through patient-centered counseling skills to support education on trigger avoidance, medication adherence, as well as emergency planning during pregnancy. And then lastly, we're going to apply some evidence-based clinical guidelines for asthma management in pregnant patients, including appropriate pharmacologic treatment as well as ongoing monitoring. So I always like to start my lectures with the goal or the end in mind. And for this talk, I think we can all agree that our goal is to have a healthy mom and a healthy baby. So with that goal in mind, the other concepts that we're going to talk about are the impact of asthma on pregnancy. We're going to talk about education as well as management. We'll go ahead and get started by talking about the epidemiology of asthma and pregnancy. I think it's important to realize that allergic diseases occur in up to 20% of women of childbearing age, with asthma reported in 8 to 9% of pregnant women. It is the most common obstructive pulmonary disease of pregnancy. And the disparities that we see in asthma epidemiology, just in non pregnant individuals, we also see that in pregnant women as well, with Black women experiencing increased asthma morbidity during pregnancy. The figure that I have here is just to highlight the fact that asthma and pregnancy, these two conditions affect each other. So, asthma obviously can impact the course of pregnancy, and then pregnancy obviously can have some significant impacts on asthma control and management for these individuals. So, this figure shows a list of the different perinatal complications that have been described in asthmatic women during pregnancy. So, the risk overall is small but significant. Anywhere from 15 to 20% of asthmatic women who are pregnant will face a type of complication during pregnancy. That risk can go up higher depending on the severity or the classification of asthma, or if asthma is uncontrolled during pregnancy, to as high as 30% or even greater than that. And as you can see here, the complications can really vary anywhere from, fetal perinatal complications like preterm birth, perinatal mortality, preeclampsia for the mothers, as well as gestational diabetes. This table kind of highlights those different complications, but now it kind of breaks it down based on whether it impacts the mom or the fetus, as well as occurrence of perinatal complications. I do think it's also important to realize that some studies have actually pointed to a differential risk for some of these complications. So, for example, cesarean or C-section delivery, there's actually a higher risk for C-section delivery depending on the maternal asthma severity or classification, with severe asthma having an increased risk compared to mild asthma. I also think it's important that this is an aspect that we could potentially change. Preterm delivery, or the risk of preterm delivery, can actually be decreased by having active asthma management during the pregnancy. So, again, a role for the healthcare provider to actually impact these perinatal outcomes. So let's talk briefly about pregnancy and respiratory physiology, because I think it's important to understand perhaps a reason why we see these complications. So in the mom, typically during pregnancy, you'll see an increased minute ventilation, which is thought to be related to increased circulating progesterone levels. This leads to a lower PaCO2, or the carbon dioxide, and then an increase in PaO2, which results in a respiratory alkalosis. Mom will typically compensate by excreting bicarb in the urine. In the fetus, the PaO2, or the arterial O2 concentration, is a third to one quarter of adult levels. And typically, the fetus compensates for this by having differences in the fetal hemoglobin and oxyhemoglobin dissociation curves. When it comes to O2 delivery for the fetus, two of the important factors that we have to take into consideration are the maternal cardiac output as well as maternal oxygenation. If we maximize both of those factors, then we can ensure that the fetus is getting sufficient oxygen. So, what happens when we have complications or when one of those factors is not maximized? So, take for instance maternal hypoxia, such as that can be seen with uncontrolled asthma or with moms that are experiencing asthma exacerbations. What ends up happening is that the fetus will compensate for that decreased oxygen supply by redistributing their circulation to vital organs. Clinically, the prenatal providers and the patient might experience or notice decreased gross movements. The fetus also tries to extract more oxygen through tissues. And then chronic impact is that the fetus will actually have decreased growth because of that, shunting of oxygen to those vital organs. So clinically, these are patients that might have intrauterine growth restriction or small for gestational age infants. So again, this is kind of the theory behind why maternal hypoxia can have such a huge impact on fetal growth as well as perinatal complications. So there's definitely other factors that can impact morbidity as well. So I think I've already alluded to asthma severity. Specifically, poorly uncontrolled symptoms can have a huge impact and increased risk for maternal as well as fetal health. Moms are also at increased risk of susceptibility to viral upper respiratory infections. The concept of medication non-adherence, we're going to talk about in a little bit as well, because it is also very important to consider in pregnant women. They are also at increased risk for exacerbations from other factors. So, some of these other factors include or psychosocial factors such as increased anxiety, as well as environmental factors like tobacco use. Under treatment by physicians has actually been explored in the literature. So we'll come back to that in a little bit as well to talk about how that impacts morbidity. And I think in red here, think the big takeaway from this talk is the fact that adequate control of asthma is really the most important therapeutic intervention to optimize perinatal outcomes. All right, so let's talk a little bit about the asthma course in pregnancy. So there was a study done in 1988 by Dr. Schatz, and what he did or they did was that they took 300 pregnant patients and followed them prospectively to see or to study the course of asthma during their pregnancy. And what they noted was we typically talk about the rule of thirds for asthma and pregnancy is that a third of the women had no change in their asthma during pregnancy, a third got worse, and a third got better. There's been some subsequent studies since that time. The most recent one was done in 2022. Again, very similar in that they also followed over 300 pregnancies. And what they noticed was that 60% of the women actually had no change in their asthma during pregnancy, and 40% actually worsened. They did not see any pregnant individuals who had improvement in their asthma in that cohort. When they looked further at the factors that maybe predispose somebody to have increased or worsening symptoms during pregnancy, what they noticed was that that cohort, so that 40% was more likely to be younger, to be Black or Hispanic, to be multiparous or obese, also increased likelihood that they had lower income or education, increased likelihood that they had other underlying uh, medical disorders prior to pregnancy, such as pre-pregnancy hypertension, and then they also tended to have poor baseline asthma control as well as higher baseline severity of their asthma. When we talk about these asthma exacerbations, they can occur in 20 to 45% of pregnant women. There's a study looking at over 1,700 pregnancies, and what they found was that exacerbations can occur in asthma of any severity or any classification. So, in those 1,700 pregnancies, they noticed that 12% of mild asthmatics went on to have an exacerbation, but a quarter of moderate asthmatics could have exacerbations. And obviously, the largest group was the severe asthmatic, with over 50% of them experiencing an exacerbation during pregnancy. The grading of exacerbations was had a wide range. About 10% of exacerbations are severe in nature, and about 2 to 10% require oral corticosteroids, depending on the study population that you look at. So, there's an additional study. This was a systematic review and meta analysis of over 400,000 pregnant women. I'm showing you here the different factors that were studied in this specific meta analysis and the relative risk of exacerbation based on each of those factors. The largest factor was, like I mentioned already, kind of having more moderate or severe asthma with a relative risk of over three. I do have highlighted here some factors in red, which I think is important to note that these are modifiable things. These are things that, or factors that we as healthcare providers can help our patients improve on to hopefully decrease that risk of exacerbation. So these factors include, again, the psychosocial, behavioral, so depression, anxiety, maternal smoking, maternal obesity. We can help assist our patients have improved perinatal outcomes by monitoring and providing medication and therapeutics for those factors. When it comes to timing for exacerbations, the peak incidence of exacerbations occurs in the second trimester, more specifically in the 6th month or at the end of the 6th month of pregnancy. And the third trimester, there's actually a decrease. Incidence of exacerbations, with the lowest number of exacerbations or less frequent exacerbations occurring in the last 4 weeks of pregnancy. Typically, because symptoms have improved by the last trimester. Asthma typically doesn't present from a symptomatic standpoint during labor and delivery. It can occur 10 to 15% of the time, but it typically does not interfere with the labor and delivery process itself. The postpartum course can be variable. In one study, asthma symptoms returned to baseline in the first 3 months after delivery in about 73% of women. In women whose asthma improved during pregnancy, about 58% of them actually noted worsening of asthma postpartum. And then there's been studies showing that the course of asthma during pregnancy is concordant with future pregnancies. So, again, that kind of helps with the prognosis with future pregnancies. I also think it's important to talk about the differential diagnosis. So, most of the patients with pregnancy and asthma will have pre existing asthma. When you have patients that come in with new onset symptoms, this is where obviously the differential becomes really important. We want to make sure that we have not missed other potential pregnancy related conditions that can present with similar symptoms. So, common condition that is typically benign is dyspnea of pregnancy, which is seen in up to 75% of pregnant women. It's typically related to the physiologic hyperventilation of pregnancy and usually starts in the first and second trimester. Typically, the symptom that you're going to have is dyspnea, difficulty kind of catching your breath. When you start hearing that patients are complaining of cough or wheezing, that should really trigger you to think that maybe something else is going on because both of those symptoms tend to be more prevalent in asthma. Obviously, there's other conditions that can mimic asthma, and obviously are more concerning. Other conditions like peripartum cardiomyopathy, which usually occurs during the first 6 months after delivery, but can also occur at the end of pregnancy. And then there's other conditions like GERD, upper airway cough syndrome, laryngeal dysfunction, pulmonary embolism, obviously that can complicate pregnancy. So we want to make sure that we have a high index of suspicion if patients are presenting with other symptoms. Um, and definitely, if they don't have a pre existing diagnosis of asthma, we really want to make sure that we're evaluating these patients to rule those conditions out. Okay, so we've covered impact. So, next, we're going to move on and talk a little bit about education. I think it's important to realize that the education that we provide our pregnant patients really has to strike a really delicate balance. Pregnancy introduces new complexities in the education as well as management. Ultimately, you are treating two patients. And I do think it's important to, be upfront and with our patients and help them understand that in an ideal world, we'd avoid medications during pregnancy altogether. However, as I've kind of stressed through the talk already, we want to make sure that they are aware that uncontrolled asthma can also pose significant risk for both the mom and the fetus. It can disrupt sleep and daily functioning. It can actually decrease overall maternal well being. And then ultimately, it can undermine that mom baby dyad through all those cumulative health effects. I think the risk benefit discussion needs to be nuanced as well. In general, most drugs are not thought to harm the fetus, but ultimately, there is no medication that can be considered absolutely safe. Again, the risk of undertreating or inadequately controlled allergic disease also poses a risk to both the mom and the fetus. And then I do think we need to have or be able to have the discussion and be able to review alternate medication choices with our patients, as well as the rationale for choosing one medication class or medication choice over others. The timing of education is important as well. In an ideal world, we are having these discussions as well as education in the preconception setting. And the reason for that is that is going to allow for patient centered and tailored recommendations. It will give us time to perhaps work on that asthma control before conception occurs. And then again, we can stress the importance of education during the pregnancy in that preconception time. During pregnancy, our goal is obviously to maintain and achieve control to prevent morbidity. And then after delivery, we want to maintain that control, that asthma control, as well as offer long-term prognosis as well as expectations for our patients. So there's been some research done on the impact of education on asthma. This study was a prospective cohort done in Australia that provided education on asthma control, management of management and trigger avoidance for women that were at about 20 weeks estimated gestational age. The education was provided by a nurse educator. They brought the patients back at 33 weeks, and what they noted was that with that education, those patients reported decreased self-reported inhaled steroid non-adherence, as well as decreased inadequate inhaler technique, and they did notice improved asthma medication knowledge. They were more likely to possess an asthma action plan and also were more likely to be doing peak flows to monitor their asthma. When they divided up the groups based on asthma severity, they noted that severe asthmatics actually had a reduction in nighttime symptoms as well as decreased use of reliever medication. So, again, I show the study to highlight the fact that, a potentially low cost, education program early on in pregnancy can have significant impact when it comes to kind of those perinatal outcomes and complications that I've discussed. The principles of asthma education are largely the same as for non pregnant patients with asthma. Obviously, we want to stress and educate our patients on early recognition of signs and symptoms of exacerbations. We want to talk about avoidance of triggers, the ongoing and correct use of medications, as well as provide them with a treatment plan for acute exacerbations. On the table here, I do want to highlight adherence to treatment, and we'll come back and talk about this, but unfortunately, pregnant women stop their medications because of a multitude of reasons. So, anytime we're providing education, we want to make sure that we are also addressing that, addressing any concerns that they may have to make sure that, they go back on the medicines. Okay. When it comes to preventive strategies, so as an allergist, I spend a lot of my time talking about allergen avoidance. Uh, Ultimately, for pregnant women, allergen avoidance might decrease the need for pharmacologic management. I do think it's important to try and provide patient specific avoidance recommendations. Obviously, we try to do that based on allergen testing. Typically, we don't do allergy testing or skin testing during pregnancy, but we could consider blood work like serology testing, and then obviously, if we have testing that's done prior to conception, we can utilize that to make those patient specific recommendations. I also think it's key to remember that there may be other non allergic triggers that could be triggering our patients. So, exposures like tobacco smoke, pollution may also trigger the same type of symptoms. So, we want to counsel patients about avoidance measures of those irritant triggers. Allergen immunotherapy can be considered. Typically, we don't start it during pregnancy because of the potential risk for systemic reactions. However, if a woman of a childbearing age is already on allergy shots and deriving benefit from the shots and then becomes pregnant, we can typically continue allergy shots for that patient. So, a little bit more about smoking cessation. I've addressed this a couple of times already, but I think it's important to realize that tobacco use alone, so even outside of asthma, it is associated with preterm premature rupture of membranes, placental abruption, and other complications. So, again, this is why it's important to address this with our patients and to come up with a plan and a strategy to hopefully get them to smoking cessation. We obviously want to maintain our patients healthy, so we want to prevent having them get illnesses. So, vaccine recommendations or following routine vaccine recommendations is important as well. So, annually, they should be receiving the annual influenza vaccine, SARS-CoV-2, maternal RSV vaccine was approved a few years ago. Obviously, pneumonia vaccine as well, and tetanus and a pertussis booster. Okay, I'm showing here two asthma action plans. They're both the same. One is in English and one is in Spanish. This is from the American Academy of Allergy, Asthma, and Immunology, so it's available for free. These action plans are specific to pregnancy. So what they do is they add in, the pregnancy consideration or maybe pregnancy related signs and symptoms that we want to be specific about for our patients. So, for instance, having moms track fetal movements is important. Red zone adds in things like headache, vomiting, vaginal bleeding. Again, making the action plan very specific to our pregnant patients becomes important when it comes to that emergency planning. All right, so I'm going to move on now to management. Management in general is the same as for non pregnant asthmatics. Our goals are also the same. We want to decrease and prevent exacerbations. We want to maintain normal lung function. And obviously, we want to prevent interference with normal activities. I do think it's important to realize that if you are the asthma manager for these patients, you are going to, we really should be partnering with the prenatal care provider for our patients because obviously this can be a team effort to make sure that we get the patient and the baby to that end goal of health. It also requires regular follow up visits as well as monitoring to make sure that we are controlling symptoms should they occur. This is a table from a New England journal to kind of highlight the just the concept of assessment of asthma control in pregnancy. It's the same as for non-pregnant asthmatics in that we at every visit we should be talking about the frequency of symptoms, whether they're happening daily or nightly, how often the patient is using rescue medications, if we have any objective data like FEV1 or peak flow numbers, utilizing those numbers to help establish whether the patient is well controlled, not well controlled, or whether they have poorly controlled asthma, because that's going to inform our next step in management. So I also wanted to show you the pregnancy asthma control test or ACT. Again, there's a version in English and a version in Spanish that is also free and available to use. The key here, similar to the action plan, is that it's nuanced and it's a little bit more specific for pregnancy. Question 2 for the pregnancy ACT tries to differentiate between shortness of breath related to asthma versus that dyspnea of pregnancy that I mentioned. So again, utilize these resources when you're seeing pregnant asthmatic women. Routine monitoring typically is symptom based, but I also wanted to talk about some other ways to monitor these patients. So consider using a peak expiratory flow meter to help give you some objective data, FEV1 measurements using a portable device, especially now that portable devices have become more common, is something to consider. We'll come back and talk about spirometry measurements in just a second. But I wanted to talk also about FeNO, which is the fractional exhaled nitric oxide value that can be obtained. This study was a double blind parallel group randomized trial that used FeNO to adjust the inhaled corticosteroid dose in a group of pregnant women. And what they noticed was that using FeNO actually decreased the exacerbation rates compared to placebo with a number needed to treat of 6. It improved quality of life as well as decreased neonatal hospitalization. So, again, just to kind of highlight using these additional tools that we have to provide objective data and evidence to manage the medications, I think is important. So, this is a figure from Up to Date that highlights the changes that we see in spirometry values during pregnancy. In general, spirometry does not change much during pregnancy. There is a decrease at the second and third trimester in some values, like the functional residual capacity as well as the residual volume. But overall, spirometry remains largely the same. So it does become another objective measure for monitoring our patients. The values that we typically look for when it comes to asthma, values like your forced vital capacity, your FEV1, that ratio between those two remains the same during pregnancy. So, again, that's another objective measure that you can use to then follow our patients during their pregnancy. All right, so monitoring. So, obviously, the ideal world is patients are coming to see us, it's face to face visits. But I also wanted to highlight the fact that telemedicine has been studied in pregnancy and it has been shown to improve obstetric outcomes, reduce smoking rates, improve breastfeeding, and improve monitoring for high risk patients. There was a randomized control trial in Australia that used a multimodal intervention. They use handheld respiratory devices, a smartphone application, and then a written action plan for pregnant women. They who then track their daily symptoms. They uploaded that data to a central server, and then on the other end was an asthma educator who reviewed the data and then contacted a healthcare provider if they noticed any changes or if they thought any intervention was needed. And what they found in the study was that the intervention group had better asthma control as well as improved asthma related quality of life at 6 months compared to the usual care. So again, these are some newer techniques that perhaps if depending on where you practice, um, maybe not too intensive in terms of adding additional monitoring for our patients. All right. So I did briefly talk about this earlier, but I wanted to spend some time talking about non-adherence because I do think it's an issue with in pregnancy. Um, there was a systematic review and meta-analysis that evaluated the use of inhaled steroids during pregnancy. What they found was that the pooled prevalence of inhaled steroid use was only 41%, with it lower in North America, it was only 34%. I think the timing of nine adherence is important. So they looked at prescription rates, and what they noticed was that those prescription rates for that inhaled steroid decreased in the first trimester compared to pre-pregnancy. They Prescriptions increased during the second trimester and then decreased once again in the third trimester. And I think if you'll recall, going back to the discussion about when exacerbations occur, it matches those prescription rates, right? Remember that exacerbations are more common in that second trimester, and then they decrease in the third trimester. So again, both of these track. When patients were asked in this study, or when they pulled the analysis, they noted self-report non-adherence to be at 40%, which is pretty significant. So I think there's lots of factors that impact adherence. So we're going to talk through some of these together. So, first off, I think professional education is important. I know this is perhaps a really hard slide to read, so we're going to walk through it together. So, what this study it was a survey that was done in Spain. They sent the survey out to 1,000 healthcare providers of different specialties. So, there were primary care healthcare providers, allergists, pulmonary doctors, as well as OB-GYNs. And what they did is they asked these providers to essentially answer some questions regarding how they manage asthma in pregnancy. A couple of questions that stood out to me. One of the questions they asked was the use of guidelines for pregnant asthmatic patients. And just focusing on the overall results, 64% of these providers said they never or use these guidelines only a little. 27% they frequently use the guidelines, and only 8.7% said they always use guidelines. The next question that stood out to me was the attitude towards maintenance asthmatic therapy. And again, just focusing on the overall numbers, 17.6% said that they sent their asthmatic pregnant patient to a specialist. 55% say that they maintain the previous medication regimen. A quarter, or 25%, use only on demand medication. And then 1% withdraw all medications. And again, as an allergist, looking at some of these allergy numbers, 26% of allergists use only on demand medications for pregnant individuals. So, again, I think professional healthcare provider education is so important. Obviously, you're here in this talk learning more about this, which is it's good for our patients. All right. I think another big factor that feeds into non-adherence is the perceived risk, specifically congenital malformations. So, in the general population, major anatomic congenital malformations are seen in 2 to 4% of newborns. An additional 2% become apparent by the age of 1. When we look at reasons for these congenital malformations, genetics makes up about 25%, environmental factors make up about 10% of the background for these malformations. And of these, only 1 to 5% are thought to be caused by medications, and then the vast majority of these malformations are due to unknown factors. And that makes up the vast majority, and that's at 65%. Um, there's conflicting data. We have lots of studies regarding asthma and medications in asthma, but unfortunately, a lot of these studies are mostly observational with different endpoints, different populations. So they are difficult to compare. To kind of highlight just the complexity of the data, I wanted to show you or talk through these two studies. So the first study was a Canadian cohort study that in 2009, they followed over 13,000 pregnancies. And what they noted was that women who use more than 1,000 micrograms per day of an inhaled steroid, specifically beclomethasone CFC, which is equivalent to about 500 micrograms of fluticasone HFA, they noticed that those women had a 63% increased risk of malformations. So, again, maybe speaking to the dose or the amount of inhaled steroid perhaps being associated with greater risk. A separate study was a meta-analysis in 2013, noted that maternal asthma was associated with a small risk of cleft lip and palate, but there is no association with exacerbations or bronchodilator use or inhaled steroids. So again, I use this study to highlight the fact that, perhaps it's not the medicine, perhaps it's just having underlying asthma that might put patients at risk of malformations. So I did want to spend some time just briefly going over or summarizing the data for the different medication classes that we use in asthma. Again, it's difficult to go through each individual study, so I wanted to give you just kind of the summary because, again, patients are going to want to know this information. They're going to want to know what the data is. So, starting off with short acting beta agonists in general, they're not thought to increase or be associated with major birth defects. There are some studies pointing towards a modest increased risk of isolated defects, specifically cleft lip or cleft palate, as well as cardiac malformations and GI malformations with odds ratios less than 3. Short acting beta agonists are not thought to increase perinatal complications such as preterm delivery, low birth weight, or small for gestational age infants. For any inhaled corticosteroids, similarly, they're not thought to increase the risk of major birth defects. And regarding birth outcomes, like I mentioned in the previous slide, higher doses of inhaled steroids might have some association, not just with malformations, but also preterm delivery as well as low birth weight infants. Long acting beta agonists are not thought to increase major birth defects. There is one database study that showed increased risk with trimester exposure. So maybe the timing is the factor there, but no known difference with preterm or low birth weight infants in mothers exposed to those long acting beta agonists. Leukotriene receptor antagonists are not thought to increase major birth defects or have uh, other birth outcomes. And then systemic corticosteroids, again, typically not associated with increased risk of major birth defects. However, there are some case controlled studies that show a threefold increased risk of oral clefts, although that's been an inconsistent finding in all the studies. When it comes to other birth outcomes, systemic corticosteroids have been associated with preterm delivery, low birth weight infants, as well as maternal complications like preeclampsia and gestational diabetes. However, in those studies, the studies that control for underlying maternal disease, those risks tend to be reduced or eliminated. Again, speaking to just that concept that it may not be the medication, it might be that underlying asthma history or asthma control that maybe is predisposing these patients to those risks. Okay. Alluded to this already, but the timing of medication use is important. Safety profile of medications or medication classes can change depending on the stage of pregnancy, with a safer profile or an improved profile after organogenesis has completed, so after the first trimester. Overall, there is a preference of for inhaled therapies over systemic medications, again, because we want to decrease systemic absorption and obviously concern for transplacental transfer. Also wanted to touch briefly about FDA medication classification. So prior to 2015, the FDA used letter categories A, B, C, D, and X when it came to medication classification. Um, in 2015, this changed. And the reason for that is there was some concern that arose that labeling was perhaps overly simplistic. We were misclassifying, or there was a misconception that for instance, category A medications were being viewed as safer than category X. So in 2015, the pregnancy and lactation labeling rule was implemented. And essentially, what that did is it replaced those letter categories with narrative summaries that actually just give you a more detailed summary of the risks associated with medications during pregnancy and lactation. So I know this is really hard to read, and we're not going to read this. I just wanted to show you an example of a narrative summary for a drug. Kind of highlighted in those red boxes is the different factors that go into these summaries. So these summaries include a pregnancy exposure registry. So typically there's information if there's a registry that's ongoing for healthcare providers to enroll their patients or encourage patients to self enroll. There is a risk summary that includes a summary of the clinical trials that's included. Clinical considerations, again, speaks to the maternal or fetal risk associated with that drug. And then the data presented includes the data that has been published on that drug. Okay. So, big picture, in terms of medication recommendations, typically, if you're going to use a short-acting beta agonist, which are we should for our asthmatics, albuterol is the best studied. For inhaled corticosteroids, budesonide and fluticasone can be considered as starting medications if needed during pregnancy. However, if a pregnant woman is already on an inhaled steroid that is not budesonide or fluticasone, as long as they're deriving benefit and their asthma is controlled, it's okay to continue that medication. Long acting beta agonists, we typically want to use those in combinations with inhaled steroids. And again, it depends on symptoms or symptom control. And then we'll come back and talk about biologics in just a second. But first, I did want to address SMART therapy in pregnancy. So, SMART would be single maintenance and reliever therapy. Unfortunately, right now, there is a lack of clinical trials in pregnancy. We do extrapolate some of the data from non pregnant individuals. There are some retrospective studies that show reassuring data regarding the use of formoterol in pregnancy. And the thought is that there's comparable risk of congenital malformations with low dose inhaled steroids with long acting beta agonists compared to a medium dose inhaled steroid. So, obviously, this is an area of active research, and hopefully, we will have those clinical trials over the next few years to get more data. All right. So regarding the approach of asthma management, so it's very similar to non-pregnant individuals. We still want to follow step therapy management. Showing you here a table with just a summary of those steps. So obviously, we want to assess the current level of control of our patients. We once we have that assessment of control, we assess their current level. If they're inadequately controlled, then we want to obviously consider stepping up therapy. This is also a time for education where we want to talk about adherence. We want to talk about inhaler technique, avoidance of triggers, and then address any comorbidities that our patient may be experiencing. Step 4 here talks about step down therapy, with which in general we should try to do for all of our asthmatics once they're controlled. It is of a lower priority in pregnancy, however, and I think this speaks to the fact that we don't want to put our patients or the pregnant mom at risk of having an exacerbation by stepping down therapy. So again, you could definitely consider it, but perhaps lower priority than in non-pregnant individuals. All right. So this is a table showing kind of more the specific step-up therapy that follows NHLBI guidelines as well as EPR guidelines. Our first step is typically a short-acting beta agonist. Step 2 would be adding a low-dose inhaled steroid, and then so on and so forth. I did want to highlight step 5 with that red arrow. So this is typically where we would start considering a biologic medication. So, biologics and asthma, omalizumab has the most patient data. Omalizumab had the Expect pregnancy registry, which included 230 patients that were exposed to omalizumab in the first trimester. Of those patients, 99.1% of them had live births, 8% had major birth defects in the infants. The infants, 13.7% had low birth weight, and there were 15% that had preterm births. There's been some subsequent retrospective case studies that have had variable use of omalizumab throughout pregnancy. Again, limited generalization though, because the numbers, small numbers in those case studies. For other biologics, there's limited data, typically in the form of case reports for mepolizumab, benralizumab, and dupilumab. So obviously, this is an area that needs ongoing or requires research in order to be able to generalize those findings to the population. All right. I wanted to briefly talk about precision medicine. This diagram is from a European review paper that talked about just the approach to asthma management in pregnant individuals. And I think it's a really good figure and flow diagram because it highlights the fact that we not only need to assess our patients' underlying pulmonary disease, their asthma, but also help manage some of the extra pulmonary conditions that they may be experiencing. So, other conditions like GERD, sleep apnea, rhinitis, and then behavioral or environmental risk factors, things that I've alluded to already. So, tobacco, smoke, inhaler technique, adherence to medications. Once we address all of these factors, then we can come to, provide precise, patient-centered recommendations regarding their management for asthma. So obviously, this is the goal that we want to achieve. I also wanted to leave you with just, from a national standpoint, kind of the surveillance and regulation that is ongoing in the US. So there's a couple of different programs. The first one on here is the Vaccines and Medications and Pregnancy Surveillance System, or VAMPS. This is a national systematic post surveillance system for both vaccines and medications that does a lot of research regarding the use of vaccines and medications in pregnancies. The FDA also has a post approval pregnancy safety study guidance from 2019 that again reviews approaches from post marketing data collection in pregnant women, pharmacovigilance, pregnancy registries, as well as the use of electronic healthcare data. And then lastly, there's also research networks such as the Maternal Fetal Medicine Unit Network, which what they end up doing is they harness independent data centers and large populations to be able to conduct simultaneous clinical trials to again get the data that we need for medication use in our pregnant patients. Okay, so my takeaways for this webinar is that asthma is common during pregnancy and increases the maternal and fetal risk. Optimal control is essential because it's going to help improve those perinatal outcomes. We want to use evidence based medications, and routine monitoring is going to be critical, despite how complex this topic is. And then obviously, our management has to include patient education in close coordination with the prenatal care teams to make sure that we get to those outcomes that we want. So, I think Ruthie already mentioned that in a few days you'll receive a link with a provider and patient resources that are available for you to use. And with that, I'm happy to take any questions.
Thank you so much, Dr. Adams. That was a great presentation. Definitely a topic that is really needed, especially in the among pregnant women, right? It's always difficult, especially in pregnancy, that there aren't a lot of studies conducted on pregnant women. So with that comes some challenges as far as medications and what is available to take. So we have a
Yeah.
questions. So, for pregnant patient presenting with new onset or worsening asthma symptoms, what are the initial diagnostic steps to evaluate for asthma? And is this any different for non-asthmatic patients?
Yeah, thank you. Great question. So, the initial steps are very similar than compared to non-pregnant individuals, with maybe one exception. So, typically, spirometry. Obviously, we want to get objective data, objective evidence that there is obstruction. So, doing spirometry with pre and post bronchodilator is definitely a test that you can do to try and get to that evidence. Using that FeNO level can help give you not perhaps not diagnostic for asthma, but evidence that you might have atopic or allergic asthma. The one caveat is we typically don't want to uh, induce bronchospasm in our pregnant patients, right? Because again, we want to maintain that oxygenation. So typically, we won't order methacholine challenges on our asthmatic pregnant individuals. It is something that you can definitely consider after delivery, but during pregnancy, you can, like I said, do spirometry, do FeNO testing to see if we can get that objective data, and then treat from then on.
Awesome. Thank you so much. Also, another question. So beyond direct asthma treatment, what are the most common comorbidities that impact asthma control in the pregnant patient?
Yeah. So I mentioned some of them already. Probably the most common things are going to be GERD, so heartburn. Sleep apnea is obviously can obviously co-occur with asthma. Allergic rhinitis, right? So having pollen triggered rhinitis. There's also rhinitis of pregnancy, which is thought to be hormonal as well, that can also impact quality of life. Some of these conditions can also predispose to others. So things like chronic rhinosinusitis can also kind of coexist with all of these conditions as well. There's some other conditions that eyes and allergists see. So things like inducible laryngeal obstruction or vocal cord dysfunction as well. And again, the important for all these conditions is taking a good history so that we can help diagnose them. And then once we diagnose them, then providing management in addition to the asthma management. So again, we're treating those comorbidities so that they're not impacting that asthma care.
Awesome. We have another question regarding if you could please address vaccines during pregnancy.
Yeah, so definitely want to follow the current guidelines, right? So CDC, ACIP guidelines for pregnancy for vaccines during pregnancy. I mentioned a maternal RSV vaccine. The important thing with RSV is you want to make sure that you time it correctly. And if mom can't doesn't get the maternal RSV, don't forget that there's also the pediatric monoclonal antibodies that can also provide protection for the baby. We typically want to provide a tetanus, diphtheria, and pertussis booster once during pregnancy. Obviously, the flu vaccine, like I mentioned, should be annual. COVID vaccine should be annual. Asthmatics in general should get a pneumonia vaccine as well, because again, we want to protect that risk of pneumonia, if you will, in the future. So definitely something that you want to address at every visit to make sure that your patients are staying up to date on those just routine vaccine recommendations. The only other one thing I'll mention is typically we don't provide live vaccines during pregnancy. So you want to, again, do those before preconception or after delivery.
Awesome. Thank you so much. That's interesting, and I'll kind of add a little bit of a personal anecdote. I myself am not diagnosed with asthma, but I did contract COVID during my last two pregnancies, and because of my symptoms, it was almost my OBGYN and my PCP were teetering along the line of, there's a certain amount of time after pregnancy that you should probably be evaluated by a pulmonologist or an allergist. So, kind of to that question, if a pregnant mother was to be newly diagnosed in pregnancy, how soon after or what length of time should she wait after delivering to really get that diagnosis?
Yeah, so like I mentioned, usually like I said, first few months after delivery, there's still a lot of hormonal changes that are happening, right? So, it's possible that the evaluation, may not be ideal. However, I will say if you're symptomatic, get seen, get the referral. Sometimes that takes time as well. Because once you're established with a pulmonologist or an allergist, they can then follow you and make sure that we're optimizing your medication regimen, even in the immediate postpartum period. Over time, you might notice that, as we repeat testing, we can see that there's a change. If there's going to be a change, that would be the time to do it. And you bring up an interesting point with COVID. So, not just COVID, but lots of other viruses out there, or respiratory viruses, will kind of trigger this asthma like picture. Typically, it's 4 to 6 weeks after the infection, and then symptoms get better. So, again, when I see patients, we talk a lot about when they got sick and then trying to figure out when that optimal evaluation time is. But I would say, get plugged in sooner than later. That's something that the allergist and the pulmonologist will figure out with you.
Awesome. Okay, we'll take one more question before we wrap up. There's a question regarding Flonase and your thoughts on that medication being okay during pregnancy.
Yeah, thanks. So, yes, it's a safe medication. It's fluticasone. So, like I mentioned, inhaled for asthma as well as for rhinitis. It's typically a safe medication to use. We have lots and lots of patients on this medication without any significant side effects, as well as in pregnancy or outside of pregnancy. So, I briefly touched on it, but pregnancy rhinitis is a thing, and it can be very cumbersome and impact quality of life. So, we want to treat our patients, like I said, Flonase is fine, as are other inhaled, or I'm sorry, nasal corticosteroids as well.
Awesome. Well, thank you so much for answering those questions and again for this incredibly informative and much needed topic and presentation. In a few days, Zoom will email you a link to the recording and an evaluation, as well as supplemental resources regarding today's presentation. We're also thrilled to announce two upcoming webinars that we have. Next week on July 22nd at 4 p.m. Eastern, we invite you to join us for a Back to School with Food Allergies webinar. This session will include a discussion on 504 plans and providing parents and caregivers with tools that they need to navigate the school system and communicate effectively so that we advocate for children's health and rights. And then next month, join us on August 14th at 4 p.m. Eastern for another Great Advances webinar. Join Dr. Angela Duff-Hugan in this webinar to enhance your approach to asthma management through effective patient education on inhaler technique and asthma action plans. So studies show that improper inhaler use contribute to up to 70% of asthma-related hospitalizations, and clear and accurate instructions are crucial for asthmatics. Dr. Hogan will share best practices for teaching patients proper inhaler use and improve adherence to minimize errors. Additionally, we'll explore the essential components of asthma action plans and discuss strategies for personalizing and optimizing patient outcomes. So, thank you again from all of us at the Allergy and Asthma Network. We strive daily to be your trusted resources for people with allergy, asthma, and related conditions. Thank you so much, everyone, for being with us today. And again, thank you so much, Dr. Adams, for a wonderful presentation. Thank you so much. Have a good day.